All right, well, welcome, everybody. I hope everybody on the phone can hear me. Let's see, I've got notes here that I'm just supposed to make sure, things I'm supposed to make sure I cover. So welcome to this training. I'm Jimmy Stevens. I'm the Director of the Office of Science Quality within the Office of the Associate Director for Science. And as many of you may know, we have had an ongoing activity. It's actually something I've been engaged in for gosh, I don't know how many years, 7 or 8 years. But more recently, we've had a group that's been looking at improving the quality of guidelines across CDC, and I'll talk a little bit more about that in a second. And by the way, in addition to those of you, as you probably could tell from this, we've got a number of people on the bridge line. We had actually quite a lot of interest in this, and one of the things that we're hoping to do is continue to identify courses that people will find a benefit. And so please give us feedback on, is this course meeting your needs? Are there other areas that you think would be of interest? There again, I mean, we seem to have a lot of interest, and we had quite a bit more people signing up for this course than we could accommodate. So we'll certainly continue to do repeats of this course if that seems to be the most appropriate, or to identify other training that people will find of use. Let me ask, if I can ask the OADS staff to identify themselves. I don't know if people on the phone will be able to hear you.
Good morning, this is Julie Orta. I lead the training unit in the Office of the Associate Director for Science. Good morning, my name is Dr. Diane Hoffman. I'm a health science advisor here in the Office of Science.
Good morning, I am Jonna Fernandez-Tules, and I am a co-lead with... Okay, and I am a co-lead with Jimmy, the guidelines and recommendations that we do science, and I do all the... So whenever you are going to start the guideline, you're in the middle of the guideline, or you're at the end of the guideline, please feel free. I am here to assist. Thank you.
And good morning, I'm Rick. Staff engaged in the third.
Okay, so if you are engaged in guidelines, if you consult us for a consultation, if your guidelines go through clearance in our office, Diane and Vilma are the folks who you're most likely to engage with, and Rick also works on general clearance. So I wanted to make sure everybody sort of could put names and faces together. You'll probably see their names on other things. So before I get started on the course, I just want to, I actually personally get a lot of questions about where the agency is going in guidelines. And in fact, I think Jane Seward at the Excellence in Science Committee just on Tuesday asked me this question, but I get a very steady stream of questions about this. So since we have a lot of people together who are working on guidelines, wanted to give you just sort of a few key points so that everybody's hearing the same thing. There seem to be a lot of questions floating around out there about what we're asking for, what we're requiring. In general, our goal, and there again, this is something that goes back quite a ways, but most recently we've had a number of discussions both with Harold Jaffe, the Associate Director for Science, with Dr. Frieden, with Excellence in Science Committee, about where the agency should be positioning itself in terms of guidelines. If you look at where other agencies are going in health and public health fields, I think you'll see that there's a lot of sophistication out there in the way that some agencies are approaching guidelines, and that more and more this is becoming the standard for how agencies are expected to develop guidelines. It's even gotten to the point, I think, when people hear the term guidelines, in many cases there's an expectation for a set of processes that go along with the guidelines. And I think when we looked worldwide, really, at how people were thinking about guidelines, it's really hard not to come to the conclusion that, maybe we have some catch-up to do in some of these areas. This has been felt, I think, very acutely by some parts of the organization. For example, it's worth, if you're talking to Larry Pickering sometime about what they heard with ACIT, they had some very blunt discussions with some of their partner organizations who really came to them a number of years ago and said, look, if you don't start using evidence-based approaches, we're going to stop endorsing your guidelines. This was, I think, really a big wake-up call for them. And so what we want to do is to help support the agency in developing more rigor around our guidelines, maybe gently pushing if needed, but mostly providing consultation, providing training opportunities so that people can see what the various methods are out there for developing guidelines and can identify what approaches are best for the guidelines within your own programs. Now, a key question that I keep getting asked is, okay, what is it you're going to require? We know our guidelines are going to probably go through your office for clearance. What are you going to ask for? Are we going to be in trouble if we don't have X, Y, or Z? We do have a document. I hope most of you have seen it, but if not, we'll make sure that, and I don't know, is there a link to the primer in any of the training materials? If not, we might want to make sure everybody gets a copy of the. Sorry? Yes. Okay, good. So if you haven't looked at the guidelines primer, please do so. There are a set of what we're calling standards in terms of what the expectations are. There again, these were standards that were developed with a lot of very heavy consultation with Excellence in Science and with a number of people who've been working on guidelines. These are the things that we're hoping that ultimately that most of our guidelines are going to meet. They include things like transparency around guidelines. Every guideline's having a method section that very clearly explains what was done in the guidelines process. It includes things like conducting a systematic review to compile the evidence for your guidelines, having a separate approach to evaluating the strength and quality of evidence using an evidence-based framework. Now, we realize that there are a lot of guidelines processes that have been underway for a long time, and so I think the real concern comes when people say, "Well, gee, we've got these guidelines. We've been working on them now for the last 2 years. Are you going to make us go back and redo things?" When we get documents to clear, we typically ask a number of questions, but we also understand that if you've had a process that's been underway for an extended period, you may not be able to do everything. You may not be able to meet everything in the standards for starters, and you may not even be able to do everything that we're asking about. Sometimes we don't know what's possible and what's not. So, for example, any guidelines document that's coming in, we think should be able to have a good method section, because hopefully everybody can explain what you did and why you did it. So that we're always asking for. On the other hand, if you didn't do a systematic review when you started your guidelines process, we understand you're probably not likely to go back and do it now. So that may be something that just hopefully if you are starting a new process, you're thinking carefully about doing a systematic review, but we're not going to say, gee, go back and do one now if you didn't do it when you started. And there may be some other things. For example, even if you didn't do a systematic review, providing sort of a clear summary of all your evidence may or may not be something you can do. Hopefully most people at least can say, okay, this is what the evidence is, lay it out in some sort of clear fashion. But we're also finding some groups we're asking, and their answer we get back is we can't do that. Ultimately, however, I think what our hope is that if you're starting a new process, that you're looking at what the most rigorous methodology is out there for doing guidelines, acquainting yourself with that, and to the extent possible, adopting some of these techniques, things like systematic reviews, things like using an evidence-based framework to do your new guidelines. I won't say that that's going to be required for absolutely 100% of things. I think there are some special cases that we have seen where that may not be feasible or may not be possible, but I think our hope is that that would at least be the default for all new guidelines. Now, that raises another question we're getting frequently: are we going to require people to use grade for their guidelines? A lot of groups, both within CDC and externally, are using grade. I would suggest, if you're starting a guidelines process, at least familiarizing yourself with the grade process in some level of detail, because there are so many groups out there that are using it. If it's something that will work for what you're doing, there may be an advantage to you in using grade, because it's the terminology, the system for scoring the strength of evidence is something that a lot of people are familiar with. So there may be some advantages there, but we also realize that some people may look at it and decide to use other approaches. Even if you do, though, I think sort of familiarizing yourself with grade has a lot of advantages, because you'll see how a rigorous process works. One of the things that we're finding that's a big challenge to people in the developing guidelines is it's almost what I would call a mindset behind guidelines development. It includes things like taking a great deal of care up front to specify the question, the research question, the guidelines, the public health question, and making sure that you tightly target your evidence base, the compilation of evidence to that question. That may seem obvious, but it's something that we tend to sort of roll up into a whole bunch of things in the ways that we've historically done guidelines. And if a great deal of care isn't taken on that up front, you may get a ways down the road and find that you don't exactly have the right question, and we've actually seen some examples of that. The second area that I would sort of put in this whole mindset category that can be a challenge is carefully separating the evidence review from the recommendations process. This seems to be just really hard sometimes for people to get their heads around. I think because it's so different than the way we normally do things. Normally, you know, historically you get people in a room, you're having discussions around evidence and recommendations kind of all at the same time. And so, but I think if you go through a process like grade, then you'll see how I think that'll help you understand, if you're not already familiar with this, I think how these separations occur and how this leads to better quality and more robust guidelines. So seeing an example, I think, is really helpful. And then if programs decide, you know, grade isn't what you want to use and there are other things that may be more appropriate, we actually even think that the programs may identify some innovative approaches to doing guidelines that may actually, you know, the approaches that other programs in CDC may want to copy. We're certainly open to that possibility. And finally, let me say that, you know, today I think in this course there are probably people at all sorts of different, I won't say levels, but all sorts of different stages in terms of guidelines development. Some of you have probably been engaged in doing evidence-based guidelines. Maybe others are just considering it. So we realize that people may be at all sorts of places. That for some of you, this may be sort of fine-tuning some skills. For others, this may be kind of immersion and jumping in. And again, we really want to identify what types of training people are going to find useful. And in addition, I want to reiterate the consultation process. So if you are planning to do a guideline, we'd really encourage you to contact our office. We would be happy to consult with you, provide whatever advice we can about the things you might want to think about, link you up with other groups in CDC that are doing guidelines processes that you might be able to follow along with or consult with. And we can do that at whatever level is useful to you. We can do that at very specific, or we are developing specific guidelines, or we can do it more broadly with, you know, we have a division, you know, our division would like to hear more about this and consult on this, or even at the center level. So, so please feel free to contact us with that. And is there anything else? Oh, okay, yes, okay, sorry. And then the final point is, just as an introduction in this, so this course is going to provide, it's going to be practical hands-on skills training. I think all of you were identified by your ADSs as being people interested in the course. I hope you are all personally interested and you weren't sort of volunteered by force, but I think we're hoping this is the best way to reach this audience. But there again, if there are others, if you're aware of others in your center who are interested in this, we'll certainly entertain having additional courses. So we're really happy to have everyone, and I will get out of the way so we can get to the real presentations.
Hello, everybody. I'm Rick Schiffman, and it is indeed a pleasure and a privilege to be here with you today. I want to personally thank Julie and Diane for what we've been through over the last month and for actually making this look like it's going to happen finally. I want to introduce my two co-facilitators. We wondered at one point if we needed two. I think sometimes we need four in order to make this kind of thing happen. They've been very busy already this morning. George Michel is a programmer analyst at the Yale Center for Medical Informatics who created the software that we're going to be using. And Jeremy Michael, two unrelated guys who spell their names the same way, is finishing his medical informatics fellowship at Yale. Declaration of interest, I have no financial conflict. I'm supported by Yale and ARC. All software that we're going to be talking about is available free of charge. I served on the Institute of Medicine Trustworthy Guidelines panel, so I think you'll find I'm a bit biased towards their conclusions, and have a number of collaborations that I want to make you aware of. We're just completing the GLIDES project at Yale, Guidelines into Decision Support, sponsored by ARC. And you can see the logos of our collaborators here. They include four guideline development groups: the American Academy of Otolaryngology, the American Urological Association, the American Academy of Pediatrics, and the American Society of Clinical Oncology, in addition to ECRI Institute that runs the National Guideline Clearinghouse. The objectives: at the conclusion of this class, you'll be able to identify and describe factors that contribute to poor guideline quality and implementability. You'll see what's wrong with them. You'll demonstrate your ability to use GemCutter, Extractor, eGLIA, and BridgeWiz software to mark up guidelines, create reports, identify barriers, and create recommendations. And hopefully you'll be able to create guideline recommendations that are clear, transparent, and implementable. The course structure includes 4 lectures: what's wrong with current guidelines, recognizing trustworthy guidelines, building better recommendations, and transforming guideline knowledge into clinical decision support. There'll be 3 hands-on sessions with 3 pieces of software, and very importantly, 7 discussion sessions with lots of asterisks, because I'm very much interested in hearing from you what the issues are and how you've resolved them. We're going to skip the introductions because it would involve somebody turning off the headset. So, with a little bit of luck now, I can get to this presentation. And unfortunately, the button is so far away that I can barely see it. My failing eyesight. What's wrong with current guidelines? In this session, what makes a guideline a public health guideline was a question that I tried to resolve early on. Julie and Diane were very intent that we talk about public health guidelines, and I wanted to make sure I understood what was different. Then we'll talk about the Institute of Medicine identified deficiencies in guidelines. In this session, focusing on articulation, evidence quality, and recommendation strength. And then we'll briefly give an overview of some instruments for appraising guideline quality. So what's a public health guideline? NICE in the UK had this NICE definition. Public health guidance makes recommendations for populations and individuals on activities, policies, and strategies that can help prevent disease or improve health. The guidance may focus on a particular topic, a particular population, or a particular setting. But even clinical practice guidelines, the ones that I deal with every day, are population-based. In fact, when the digs that guidelines people, clinical guidelines people take are, these are good for populations, but they're not good for the patient sitting across from me. So I think we're all talking about the same animal. I think that for all of our purposes, it's recommendations that differentiate guidelines from systematic reviews. Recommendations tell health professionals in whatever area they're functioning what to do and when. And what I hope to be able to show you is that most of these recommendations can be expressed as if-then rules. It's important also to recall that recommendations are the unit of implementation. You don't really implement a guideline. You take recommendations from within that guideline and implement those. So, for example, here's a recommendation from the World Health Organization. Patients with MDR-TB should be treated using mainly ambulatory care rather than models of care based principally on hospitalization. A public health guideline, I think. If the patient has MDR-TB, then treat using mainly ambulatory care. Likewise, sexually transmitted diseases treatment guidelines. For all patients with gonorrhea, every effort should be made to ensure that the patient's sex partners from the preceding 60 days are evaluated. If you're diagnosing, or if you're treating, or if you are following up a patient with gonorrhea, then make every effort to ensure that the patient's sex partners are evaluated. Use of the CDC growth charts for children aged 24 to 59 months is recommended. So if you have a child aged 24 to 59 months, then use CDC growth charts. The USPSTF recommends screening for cervical cancer in women aged 21 to 65 with cytology every 3 years, or for women aged 30 to 65 who want to lengthen the screening interval, screening with a combination of cytology and human HPV testing every 5 years. Here, the if and the thens get to be a little more complicated. What goes between those? Is it an and or an or? There's a lot of ifing and thenning in this statement, and it doesn't even include the fact that you have to be dealing with women with cervices, women with a diagnosis of high-grade precancerous cervical lesion or cervical cancer are not included. Nobody with in utero exposure to diethylstilbestrol, and not to women who are immunocompromised. So this if-then, to do this, would be a fairly complex statement, but it's still doable. And for purposes of implementation, I'm going to urge you to think about how those if-thens look. Guidelines have a lot of troubles. As early as 1999, Françoise Clouzot noted that the majority of 60 UK guidelines failed her quality criteria. And Roberto Grilli looked at 431 specialty society guidelines worldwide in 2000. 82% didn't apply explicit criteria to grade evidence. 87% didn't report whether a literature search was performed. 2/3 didn't describe what kind of professionals were involved in development. Now, a decade has gone by, a decade and a half already. Terry Schoenfeld, writing in JAMA in 1999, looked at 25 criteria and the number of guidelines out of 279 randomly selected guidelines that met these criteria. And you can see the mode and the median are up around 10 or 12. At least half of the criteria for quality were not being met. Unfortunately, in 2012, a paper appeared in the Archives of Internal Medicine, failure of clinical practice guidelines to meet the IOM standards, 2 more decades of little, if any, progress. They randomly selected 114 guidelines, looked at 18 standards from the Institute of Medicine's 25 standards, concluding, in fact, that 7 of the IOM standards were too vague to actually measure. The median number of standards satisfied was 8 out of 18. And Terry Schoenfeld wrote a commentary in Guidelines We Cannot Trust. He was referring to the Institute of Medicine report, Clinical Practice Guidelines We Can Trust. The guideline panel for the Institute of Medicine identified at least 8 significant ongoing guideline problems. The development process is still not transparent. There are conflicts of interest that are rife. Developer teams are insufficiently multidisciplinary, insufficiently balanced. Existing knowledge is not being thoroughly reviewed. Articulation of recommendations is not clear, and we're going to go through that issue in a little more detail in a moment. The evidence foundations and strength of recommendations are not explicitly recorded, reviewer input isn't broad-based, and new knowledge is not being incorporated. Here's a memorandum from British Airways that was quoted in Pilot magazine in 1996. This is an example of what I think is a not terribly clear guideline. The landing pilot is the non-handling pilot until the decision altitude call, when the handling non-landing pilot hands the handling to the non-handling landing pilot, unless the latter calls go round, in which case the handling non-landing pilot continues handling, and the non-handling landing pilot continues non-handling until the next call of land and go around is appropriate. In view of recent confusion over these rules, it was deemed necessary to restate them clearly. Now, this is a little jokey, but this isn't. This is also from Great Britain, guidance on the use of glitazones for treatment of diabetes. For people with type 2 diabetes, the use of a glitazone as second-line therapy added to either metformin or sulfonylurea as an alternative to treatment with a combination of metformin and a sulfonylurea is not recommended except for those who are unable to take metformin and a sulfonylurea in combination because of intolerance or a contraindication to one of the drugs. In this instance, the glitazone should replace in the combination the drug that's poorly tolerated or contraindicated. Now, I can't tell you how many times I've gone through this. Only once did it make sense to me. But if we turn this into an if-then statement, if a patient is unable to take the combination of metformin and sulfonylurea because of intolerance or contraindication, then the clinician should prescribe a glitazone to replace the drug that's not tolerated. This I can deal with. We think, this is a royal we think that authors should be explicit about when, that is, under precisely what circumstances, who, in the guidelines' intended audience, ought, with what level of obligation, be expected to do precisely what and to whom. If you write your recommendations that way and use the text that accompanies those recommendations to describe how and why, I think we would be a lot clearer to the people, to our audiences. And we turn this into an if-then rule that our IT colleagues can help to turn into clinical decision support, and we can turn it into denominators and numerators that can be used to create performance and other quality measures. Here's that recommendation marked up as who ought to do what under what circumstances. We regularly have to deal with ambiguous, vague, and underspecified language. Ambiguous statements are usually unintentional. Those are statements that are interpretable in more than one discrete way. It happens most often, we find, when you mix ands and ors in the same recommendation. You often wind up with a recommendation that could be interpreted in more than one way. You'll see an example of that later. Also with abbreviations. CPZ to some people means compazine, an antiemetic. To other people it means chlorpromazone, an antipsychotic. And if you're writing about CPZ, you got to be careful. More common than true ambiguity is vagueness and underspecification. Vague recommendations lack a crisp threshold in a single dimension, like when we talk about high fever or elevated liver function tests. Or they may be underspecified, lacking specificity in multiple dimensions. If the patient is sufficiently ill to warrant immediately antimicrobial therapy, then we should. Regularly, vagueness and underspecification are deliberate. That happens when there's insufficient evidence and you don't want to be crisp, when you've got a group that can't reach consensus, when there are legal concerns, you're concerned about setting a standard of care, or when there are economic reasons. This is a very good way to proceed, but it's too expensive. We think that if authors were transparent about the reason for ambiguity, vagueness, and underspecification, that would help users to understand how to take these AVUL recommendations. Because recommendations tell you what to do, verbs are very important. All of these folks This is U.S. Grant, and that's Alberto Gonzalez. I think the other folks are recognizable. Have at one point in their career talked about mistakes having been made. Mistakes were made. Don't know who did it, don't know who ought to have done it, but mistakes were made. Using passive voice masks the actor and ought to be shunned as we write guideline recommendations. And also, transitive verbs are a good idea. Transitive verbs act upon an object, and if we can specify what that object is, we're going to have clearer recommendations. It's also critical that an appropriate level of obligation is conveyed, and we'll talk more about that in a later talk this morning. A statement of fact is not a recommendation, no matter how often people try to tell us that they could be. Adjuvant hormone therapy for locally advanced breast cancer results in improved survival in the long term. Recommendation 7. Unfortunately, it doesn't tell you what to do. It gives us an important fact, a rationale for doing things. But in order for us to really have a statement that tells us what to do, clinicians should prescribe adjuvant hormone therapy for locally advanced breast cancer whenever or unless. That's a recommendation. Then we tend to hide recommendations, sometimes in very rich paragraphs with lots of text and lots of definition, but it comes down to the bottom here. It's the opinion of the expert panel that clinicians should. That's the recommendation. You'll never find it unless you boldface it, and maybe unless you put it up in the front. Now, these are seemingly straightforward interventions, but we still have very reputable people writing recommendations like this. And then the dreaded consider. When monitoring CD4 counts frequently is not possible, initiating chemoprophylaxis at a CD4 count of more than 200 but less than 250 should be considered. Therapy may be considered. Testing could be considered. What's wrong with considering this? Well, the trouble is you can't measure whether somebody's considered something. You can measure whether they've done it, but you can't measure whether it's been considered. And Peter Drucker, the management guru, says if you can't measure it, you can't manage it. And if you don't measure it, you can't improve it. And what guidelines are really all about is quality improvement. So you can't put the considers in no matter how hard it is to keep them out. Guideline problems, evidence foundations, and strength of recommendations are not explicitly recorded. And this is new thinking. I think it probably came from Gordon Guyatt about a decade and a half ago. But it's very rich thinking. It really changed my life when I came to understand what he was talking about. So many guideline authors conflate two concepts that ought to remain distinct: quality of evidence and recommendation strength. There's evidence quality for individual studies and in the aggregate of studies that bear on a particular recommendation. Evidence quality has been defined as the extent to which all aspects of a single study's design and conduct can be shown to protect against bias and inferential error. Study types, randomized controlled trials, do a better job of this perhaps than observational studies, and certainly better than expert opinion and reasoning from first principles. So we have a hierarchy of how we judge evidence quality. Then there's the whole question of how a study was conducted and its relevance to the population at hand. And then we still have another step where we have to aggregate a whole series of studies looking at consistency and magnitude of effect. You folks in this room who are experts in public health are much more expert in thinking about this than I. This is your bread and butter. But I want you to separate this out, this evidence quality, which is really just an indication in a guideline of the author's confidence in their appraisal of benefits and harms. It's based on an analysis of validity, consistency, applicability of evidence supporting a recommendation. ARC in 2002 found 82 different evidence quality rating schemes. everything from strong, moderate, to no, grade A, 1A, 1A, plus, minus. People were really having a field day in gradations of study quality judgment, and I'm not sure that we should put all that much effort into this many levels of recommendation strength. Now, guideline authors are committed to appraising this quality of evidence, as they should be, but they regularly fall short in helping the users of the guidelines to understand how to use the information. Users should almost always adhere to a recommendation that has grade A evidence, right? Well, not necessarily, because it's possible to have grade A evidence of effectiveness and have grade A evidence of harm for the same intervention. And you certainly wouldn't want to ask users to almost always adhere when there is high-quality evidence for effectiveness and harm for the same intervention. Implementers of guidelines, people who are trying to build systems that will make these recommendations work, are rarely interested in the evidence quality per se. What they want to know is the expert's assessment of the strength of recommendation. Strength of recommendation requires a subjective judgment. It's not all objective-y like we do when we grade study quality. A subjective judgment about the balance between benefits and harms, as well as an objective appraisal of evidence quality. When we're confident that benefits exceed harms, and I say confident meaning we have good evidence quality, then we can make a recommendation or a strong recommendation to do something. Likewise, when we're confident that anticipated harms or costs exceed benefits, we can make a recommendation not to do something. But when anticipated benefits are balanced by harms and costs, the best we can do is to offer a weak recommendation to do something. People have had great difficulty deciding what's the right language to label these weak recommendations, because guideline teams don't like to be weak. They like to be strong. However, I think more and more organizations are going the grade way, thank you, and using the term weak recommendations. Likewise, if evidence quality is low, we probably shouldn't be making strong recommendations about that either. So either when the evidence quality is grand and we have a balance of benefits and harms, or when evidence quality is low, no matter which way it's shifting, the best we can do is offer weak recommendations. This is a matrix that the American Academy of Pediatrics right now, I guess, is considering. We've just updated it, and I don't know what to do about the top. Benefits and harms are balanced. Benefit or harm predominates. Evidence quality on this scale, and the American Academy of Pediatrics is going to be labeling 4 types of recommendation strength: strong recommendations, recommendations, weak recommendations based on low evidence quality, and weak recommendations based on balance between benefits and harms. How should we use these recommendation strength indicators? If you have a strong recommendation, then users probably should follow this guidance unless a clear and compelling rationale for acting in a contrary manner is present. Strong recommendations are the optimal source for performance or quality measures. According to the AAP, this mid-level recommendation, what should you do with it? Well, users generally should follow such guidance, but also remain alert to new information and be sensitive to patient preference. And what about a weak recommendation? Here, patient preference should have a substantial role in influencing clinical decision-making, and it's certainly hard to hold users accountable. You don't want to be building performance measures off weak recommendations. Very briefly, I just want to run through a few appraisal instruments so you can say you've seen them. COGS, the Conference on Guideline Standardization, was held at Yale in 2003, brought together developers, disseminators, implementers using a Delphi process to define a checklist of guideline elements that ought to be described to assure validity and usability. you have the reference to this from Annals of Internal Medicine in your papers. The AGREE instrument is probably best known as a quality appraisal instrument, and AGREE 2 has come out, but it came out before the Institute of Medicine report. So to the best of my knowledge, there isn't any quality appraisal instrument that fully takes into account the Institute of Medicine report of 2011. The AGREE instrument is beautifully drawn. They have these multiple pages for each criterion. People judge whether they strongly or agree or strongly disagree, make comments, and it's a good way to think about things, but I'm not sure how up to date it is. And you're going to see later this morning about eGLIA, the guideline implementability appraisal that was developed at Yale, that looks not so much at guideline quality as at guideline implementability. Guideline quality appraisal based on IOM standards. The National Guideline Clearinghouse is planning on tightening its requirements. I did a search and found that there are 58 CDC guidelines that are currently listed on the National Guideline Clearinghouse. There'll be an announcement in June 2013 about what the tougher standards will be, but I think in general this is a good move. As we better understand what is a good guideline, that's what we should be pointing to. So in this session we talked about what makes a guideline a public health guideline. IOM identified deficiencies and just briefly mentioned some instruments for appraising guideline quality. At this point I'm going to hopefully take questions. You have noted a divergence between the guidelines that are intended for clinicians and public health professionals and the guidelines that are intended for patients and what's required for the public. I'm sorry. I think of everybody who is in the you're either in one field or the other. And the requirements for creating guidelines for those two groups are very different. So we need some standardization, it sounds like. And you didn't have the answer to how that standardization happens, do you? Okay. Thank you for the comment. Yes. Why is it being suggested that we use an if-then approach to guideline development, to guideline articulation, to recommendation articulation? I don't know of research that has looked at this. I can tell you that, here we go with some anecdotes. The American Academy of Pediatrics, an organization to which I belong, about 2005 started inserting an informatician on guideline development teams. That person's goal was to avoid ambiguous, vague, underspecified language and to make things clearer. There has been a general sense that since that person has joined each of the guideline development teams, that things have gotten better. The teams themselves believe that they understand what they're trying to articulate, and the products have become more useful in general. How do I judge more useful? It's anecdotal.
We've also seen some anecdotal information, in, for example, programs that have gone back and when they're updating guidelines, they've gotten feedback that people don't know how to interpret things, I think specifically for that reason. So sometimes programs have to go back and sort of revisit specific recommendations because they find people don't know how to interpret them. I mean, I always just use, when I'm clearing things, I always try to put myself in the position of of whoever's going to use the guidelines and say, gee, would I actually know in a specific case what to do? And I figure if we can't answer that question, it's usually because it fails that rule, and I think that's probably enough indication right there may be a problem.
Yeah, thank you. Can I rationalize the process of splitting strength of recommendation into 3 categories? Yes. In fact, I'm going to show you some empiric evidence a little later this morning if you'll hang on. Many of you are aware of the fact that the GRADE organization has two strengths of recommendations. You're either strong or you're weak. And a number of guideline developer organizations that I've worked with feel that there is an intermediate level for what they would like to say sometimes. It's not quite strong enough to have high levels of adherence, but nor is it so weak that we label it as a weak recommendation. So they stuck this thing in the middle. And we have some empiric evidence that people think that way that I'll show you in a little bit. So if I can summarize that as what good is a weak recommendation? I think it's a great question and an important question, and one that everybody who makes guideline recommendations struggles with. The answer, I think, comes from the fact that even when the evidence is poor, the folks in the room often are the world's experts on the topic, and clinicians are accustomed to going to experts when either there is good evidence or there isn't good evidence about what to do in a particular circumstance. So knowing both what the experts might suggest you do and how low the level of support is for that suggestion, I, as a clinician, would deem to be valuable. And I think many others do too. I don't want to use the word shirk responsibility, but I'll use those terms. When there isn't good evidence, they just give it an I recommendation. That is useful. It says there's no evidence, but it doesn't tell you what an expert would do under those circumstances. Weak recommendations also can limit your the range of your activities. They can say, we don't know whether it's better to observe or treat with antibiotics, but you ought to do one or the other. This question, can you say more about slide 42? Weak evidence, weak recommendation. For example, recently ACIP voted to recommend repeat Tdap vaccinations for pregnant women during every pregnancy despite lack of good evidence based on pertussis morbidity mortality among infants. Is this a weak recommendation? Does this imply that healthcare personnel shouldn't take the rec seriously? Wouldn't you like people to take these things serious? But at the same time, what if we find out that vaccinating pregnant women has some adverse fetal outcome when more evidence is put together? You might not want to have CDC's reputation on the line, having said, we strongly recommend, in the absence of efficacy and safety, that people take this recommendation and adhere to it. I think that the key is transparency. The idea is, if you've got good evidence that this is safe and effective, put it out there, tell people to do it, and enforce it. But if you don't, you need to be clear why not. Jenny Cleveland wants to know, how do you rate the strength of recommendation when the evidence is purely empiric, that is, no evidence for effectiveness of hand washing in dental settings, but there's abundant evidence in hospital settings? So that relates to what the GRADE people would say is the directness or the applicability of the study. And you need to be careful when you move to a new population. Is the dental population different from the hospital population, and in what ways? And make judgments about the applicability of this evidence in a new situation and be transparent about it. We see this all the time. Again, I hate to be so much of a pediatrician up here, but lots of times we have to apply adult studies to children because the child studies haven't been done. And each time we have to recognize that in the absence of studies on children, we may not know everything that needs to be known. How are we? So explicitness is good. I'm sorry. So the question was the why in an if-then recommendation, and is the then really a why? It's if you do something, If a combination of factors arise, then you should do something because, and I think the why is in a because clause that follows the if, then, because. Because is the why. If the patient has a bleeding disorder, then don't give them aspirin for 2 weeks before a dental procedure because they may bleed. Because we have evidence that bleeding is likely to occur under those circumstances. Well, the recommendation is if you have a patient with stroke symptoms, then get them to a stroke center because we have evidence of better morbidity and mortality for patients who are taken to stroke centers when they present with these symptoms. I'm thinking that I certainly am agreeing with you that a because statement is part of transparency, but I think it's separate from the if and separate from the then. So the question is, do we owe people an explanation for why? And a statement of what the benefit or harms would be. I certainly think that guideline writers ought to be doing that. I think the explicit statement of anticipated benefits and harms should be part of a guideline recommendation statement, as you'll see a little later. And whether you call that your why clause or your because clause or your then clause may be less important than the necessity of providing that information. Now, we unfortunately know that busy clinicians, perhaps less so busy patients, but busy clinicians often skip the why part. They just want to know, if this, then what do I do? But having the why available helps them judge the importance and the relevance and the truthfulness, the validity of the statement. So do I think that the process of grading evidence for a public health recommendation is different for the process for a clinical recommendation? As I've come to see what constitutes a public health recommendation, those USPSTF recommendations, as far as I'm concerned, are clinical. And the WHO recommendations about HIV treatment, that's a clinical recommendation. Where do I treat a patient with multi-drug resistant TB? In what setting do I treat such a patient? To me, that's, as a clinician, that's a clinical recommendation. To you as a public health professional, it's a public health recommendation. I'm not sure there's a big difference. And I don't think that the process for judging those recommendations is necessarily or should necessarily be different. So the example floated is on the basis of an animal study that shows toxicity in the workplace, making a recommendation about toxicity in the workplace. I think you would have to be very careful about stating such a recommendation without being very clear about its applicability to human populations and what we know and don't know about its applicability to human populations. And that's what our grade system and Cochrane rating systems are asking us to do. So let me just bring up what, again, the American Academy of Pediatrics does with such things. About 10 years ago, we had the anthrax scare. And the recommendation was for people who were exposed to this white powder that was going through the mail that they take Cipro. There were no studies on children preventing anthrax with Cipro. We know Cipro's got problems for kids, but a recommendation came from the American Academy of Pediatrics that Cipro be given to people who might or who were exposed to anthrax. It got an X level of evidence, not A, B, C, or D, which is the usual pattern, but an X level, which says, this is important, we're going to make a recommendation about it, but it's based on essentially no evidence that's directly applicable to people, and it is unlikely that confirming studies would ever be done. We're just not going to expose kids to anthrax and Cipro and see what happens. Yes? So thank you. The community guide, what's the name of the publication? Yes. So the community guide for creating guideline recommendations as opposed to the clinical guide. www.thecommunityguide.org has a system that is less rigorous and maybe more applicable to some public health interventions than is the grade system. Interesting. Recognizing trustworthy guidelines, the new IOM standards. You guys, I hope, are with me still. Here we go. In this session, I'm going to talk about the Institute of Medicine process, a review of the IOM standards, and what's been the response to the Institute of Medicine standards. First of all, what is the Institute of Medicine? I have to say a lot of folks, myself included, aren't entirely aware of what this group is. It's the health component of the National Academy of Sciences. It's independent, nonprofit, and non-governmental. It aims to answer healthcare-related questions posed by the government and the private sector, providing hopefully unbiased advice to healthcare decision makers and the public. The thing that the IOM has going for it is its ability to create what is perceived as unbiased advice that is generally perceived as authoritative. In 2008, Congress directed the Department of Health and Human Services to develop evidence-based methodologic standards for systematic reviews and for clinical practice guidelines. Secretary Sebelius delegated this to AHRQ. AHRQ contracted with the Institute of Medicine. The Institute of Medicine put together two committees to work in parallel with very little interaction, the Trustworthy Guidelines Committee and the Systematic Review Committee. I served on the Trustworthy Guidelines Committee, and we met in person 4 times, had multiple teleconferences. The staff reviewed more than 2,400 publications, and 4 white papers were created. We took public testimony on 2 coasts, had a public website for comments, and eventually the tireless staff created the Clinical Practice Guidelines We Can Trust document. And for those of you who haven't seen this, I really think it's a terrific document, whether you agree with every component or not. It's a terrific summary of the literature as we understood it in 2008-2010. For for 2 decades, we have gone by this old definition of clinical practice guidelines as systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. Came out in 1990, must have been quoted 10,000 times. The new definition is statements that include recommendations intended to optimize patient care, informed by a systematic review of evidence, not present the first time, and an assessment of benefits and harms of alternative care options, also not present the first time through. To be trustworthy, guidelines should be based on a systematic review, be developed by a knowledgeable, multidisciplinary panel of experts, consider important patient subgroups and patient preferences as appropriate, be based on an explicit, transparent process that minimizes distortion, bias, and conflict, provide a clear explanation of the logical relationships between alternative care options and health outcomes, and provide ratings of both quality of evidence and strength of recommendation, and be reconsidered and revised as appropriate. So the first statement from the IOM, establishing transparency. The processes by which a clinical practice guideline is developed and funded should be detailed explicitly and be publicly accessible. Key, number 1, probably 1 through 10 could all be included within this recommendation. Conflict of interest. Several IOM committees have looked at defining what is a conflict. And I'm going to give you a couple of the definitions they've come up with. A set of circumstances that creates simply a risk that professional judgment or actions regarding a primary interest will be unduly influenced by a secondary interest. Or a divergence between an individual's private interest and his or her professional obligations, such that an independent observer might reasonably question whether the individual's professional actions or decisions might be motivated by personal gain, financial, even academic advancement, clinical revenue stream, or community standing. And finally, the group recognized that there's such a thing as an intellectual conflict, where academic activities that create the potential for an attachment to a specific point of view could unduly affect an individual's judgment about specific recommendations. We see this more and more often, that individuals with a long publication history just don't want to change their thinking about a topic. Experts with conflicts, what do you do with them? The most knowledgeable individuals regarding the subject matter addressed by a guideline are frequently conflicted. These experts often possess unique insights into guideline-relevant content domains, and they may be aware of relevant information about study design, study conduct, because many of them have done these studies. It's not easily identified. So there are a number of strategies that were outlined but not selected by the Institute of Medicine. Everything from a simple disclosure through excluding conflicted members from being leaders of a guideline development panel, participation in certain restricted recommendations, formal or informal consultation being the only thing that would be allowed, or fully excluding conflicted members from panel participation. We have a continuum. And the panel was not clear that any one of these was righter or wronger. The panel suggested that prior to selection, all interests and activities potentially resulting in conflict should be declared, including current and planned, commercial and non-commercial, intellectual and institutional. That conflict should be disclosed within a guideline development group, and an explanation be provided about how that conflict might influence the process. Divestiture. Participants must divest financial investments, and their families must similarly divest and not participate in marketing activities or advisory boards for some period of time after the panel has met. Members with conflicts should be a minority of the guideline development group. The chair or co-chairs shouldn't have conflicts, and funders should have no role in CPG development. A guideline development group should be multidisciplinary and balanced, including methodologic experts, clinicians, and the populations expected to be affected, including, at least at the time of clinical question formulation and draft review, a current or former patient and a patient advocate or patient consumer organization representative. This is all very new, the consumer involvement. And strategy should be adopted to increase effective participation by patients and consumers. There are some unintended consequences of conflict of interest disclosure. Disclosure can lead to offering biased advice through strategic exaggeration, tendency to provide more biased advice to counteract the anticipated discounting. I've just told you that I'm on the board of some organization and receiving speakers' fees, so now that it's out of the bag, I can give you more biased information. Moral licensing, the often unconscious feeling that biased advice is justifiable because I warned you. I told you that I'm on this speaker's tour. So now I'm free to give you all the biased advice that I'd like to. The intersection of clinical practice guidelines and systematic reviews. Recommendation 4 from the IOM was that you should use systematic reviews that meet standards set by the IOM Committee on Standards. It would be terrific if the two committees had really interacted, but unfortunately they didn't. And the committee that created the standards for systematic reviews did a marvelous job creating an aspirational document, but the standards that they've set for building systematic reviews, Rick Schiffman's opinion, may be not attainable. It's the way things perhaps ought to be done, but they are really very, very rigorous. The guideline development group and the systematic review team should interact. And apparently there are some health services research that suggests that keeping these groups separate maintains purity and would be a good idea. And in fact, in many cases, guideline development groups and systematic review teams have not been interacting. This panel believes that that should not be the case, that the teams should interact. There's just too much back and forth. The original PICO question that is posed is just a little bit off, and we need a slightly different question answered, or we need to broaden our filtering criteria. There has to be ongoing discussion. Standards for systematic reviews are rigorous recommendations for initiating, finding, and assessing studies, synthesizing a body of evidence, and reporting. So must a trustworthy guideline be informed by high-quality evidence? And how do IOM standards deal with poor or absent evidence? The best way is with transparency, and the recommendations suggest what to be transparent about. For each recommendation in a guideline, the IOM suggests that there should be a summary of the relevant available evidence, a description of its quality, quantity, and consistency of the aggregate available evidence, a clear description of potential benefits and harms, an explanation of the part played by values and opinion and theory and clinical experience, which we know to be important, that we're not excluding this, but we want an explanation of what part they play in deriving recommendations. A description of any differences of opinion that remain after the group has had their deliberations. A rating of the level of confidence in the evidence quality, and a rating of the strength of the recommendation. 2 separate bullets for each recommendation. Determinants of evidence quality. Grade tells us that RCTs start high, observational studies start low. There are factors that can lower the quality of an individual study. Limitations of design or execution, inconsistency, indirectness, publication bias, and imprecision. There are factors that can increase the quality of an observational study when there's a large magnitude of effect, when all plausible confounding may be working to reduce the demonstrated effect, when there is a demonstrated dose-response gradient. I'm going to go past that and talk about articulating recommendations. Guideline development groups should articulate recommendations in a standardized form, detailing precisely what the recommended action is and under what circumstances it should be performed. Then, if, or if, then, and because. Strong recommendations ought to be worded so that you can evaluate compliance, because it's the strong recommendations that we are going to turn into quality measures. Under what circumstances, who ought to do what to whom, how and why. If they fit, you could certainly put them into the bold-face recommendation, but if they don't, they need to be in the accompanying text. You need to be explaining how to do it and why you think it's important. What is the evidence supporting this? External review. External reviewers should comprise a full spectrum of relevant stakeholders, including scientific and clinical experts, obviously, but also organizations, agencies, patients, and representatives of the public. The authorship of external reviews should be kept confidential unless that protection has been waived. The guideline development group should consider all external reviewer comments keep a written record of the rationale for modifying or not modifying a guideline recommendation in response to reviewers' comments, and a draft of the guideline prior to the final draft should be made available to the general public for comment. This is very new thinking, but a number of organizations are doing it and not having the problems that you might expect. And then finally, updating. Guideline publication date, date of systematic evidence review, proposed date for future review ought to be documented in the guidelines. Literature needs to be monitored to identify the emergence of new, potentially relevant evidence and to evaluate the continued validity of the guideline. Guidelines obviously should be updated when new evidence suggests the need. In the private sector, there are often not funds for this horizon scanning and updating, and that's a major issue for a lot of organizations. So, can we use these new standards that require transparency, reduce conflict of interest, assure multidisciplinary and balanced developer team composition, promote a thorough and unbiased review of existing knowledge, encourage clear, transparent articulation, accommodate broad-based reviewer input, and encourage awareness and incorporation of new knowledge? To the extent that we do all these things, I certainly think that our products will be better products, products we can be proud of. The IOM said that to be trustworthy, a clinical practice guideline should comply with all of these proposed standards. Optimally, guideline developers should adhere to these proposed standards, and users ought to adopt guidelines that are compliant with these proposed standards. And the committee found it necessary to insert this clause. We're sympathetic to the time and other resource requirements these standards imply. So is it worthwhile to produce a guideline that's based on poor quality evidence and expert opinion, but developed with a rigorous methodology, what we're promoting, and in response to a question that was asked earlier? Worthwhile? Well, every day clinicians treat patients, and patients seek health information with problems whose solution lacks a strong evidence base. We look for help with our decision-making. Input from experts is valued. Guidelines can provide a convenient resource that defines what we understand to be current best practice. The American College of Cardiology, the group that has what I think are the most randomized controlled trials that exist. They have trials on everything, it seems like. In fact, only 314 recommendations of 2,711 were classified as level of evidence A, that is, multiple RCTs or meta-analyses, whereas 1,246 American College of Cardiology guidelines were evidence level C. Despite their high level of precision, clinical trials are often limited in scope, they want us to remember, with evidence from RCTs often insufficient to inform general practice. So even though they may be the be-all, end-all, they may not answer a particular question for a particular patient who's outside the realm of an RCT. The American Academy of Pediatrics did a member survey. People pay $600 a year in order to belong to this organization. Fully a quarter of them stated that practice guidelines were the #1 reason they were coming up with their dues. And professional societies, many organizations are updating their guideline development processes in response to the IOM report. The Council of Medical Specialty Societies has essentially adopted the IOM standards. The American Cancer Society, which has not been in the forefront of evidence-based practice, really were very forthright and came out in December of 2011, just 6 months after the IOM report, with a listing of the standards from the IOM, a clearer statement of the recommendations, and what the American Cancer Society was going to do to adhere to those recommendations. What do we do with these standards? In the UK, the National Institute for Clinical Excellence, I think that's nice, right? certifies organizations whose methodology has been approved. An organization applies for certification, and NICE reviews their procedures and their products using largely the AGREE tool that I showed you earlier, the measurement of guideline quality. And they have both internal to NICE and external reviewers all over the world. A draft decision gets posted on the website. So if you are not meeting criteria, this becomes publicly known. But organizations that meet accreditation requirements and agree to maintain their approved processes during a 3-year accreditation period, they get a good housekeeping seal of approval to be placed on future guidelines. Good for 3 years, needs to be renewed. The alternative to doing this is to have some agency that takes published guidelines as they're published and reviews each one for its quality. And I just think, and I think a lot of people agree with me, that that is not something that is practical with the current volume of guidelines that are coming out and being regularly updated. The IOM recommended that ARC should require the National Guidelines Clearinghouse to provide a clear indication of the extent to which clinical practice guidelines submitted adhere to standards. The committee heard testimony that the National Guidelines Clearinghouse doesn't set sufficiently high standards to assure users that poor quality guidelines aren't admitted. And what we heard was that people think that if a guideline is on the National Guideline Clearinghouse, ARC has approved it. And that is certainly not the case. So they are tightening things up, not at a terribly fast pace, as I think you'll see, but we await the June standard release. NGC should eliminate guidelines for which trustworthiness cannot be determined, identify the trustworthiness of those retained. And guidelines that have not included a thorough systematic review of the relevant scientific evidence should be excluded from the NGC. Findings of no scientific evidence resulting from a systematic review shouldn't preclude listing. So you have to try to find it. If it's not out there, you have to say there isn't any evidence and this is what we think you should do. NGC should prominently identify guidelines originating from developers who are certified. Guidelines from an organization that requested and failed review should also be identified in a special category. NGC needs to be funded at a sufficient level to improve the quality, timeliness, and trustworthiness of what it's doing. And that's the end of my presentation. Thank you again. How should CDC deal with the situation that sometimes internal folks partner with external folks who may or may not have conflicts? And why should funders not be involved in guideline development? Okay, is that fair? Sort of fair? So if you're making recommendations about a brand new pacemaker, and the pacemaker manufacturer has arranged for everybody to go to Bermuda to create a guideline, and in fact they're having 2 of their salesmen sit on the guideline development panel, it's really very clear that you may get a biased outcome. What's less clear is what happens with one of your external advisors who is certainly an expert, but who has stock in a pacemaker company. Should he or she be precluded from serving? Should they simply tell people that I have stock? And the IOM would say, if you've got stock, you've got to sell it before you can serve on this panel, as should all your family members. The problem of conflict of interest is really both serious and, I hate to use the term rampant, but it's regular. Looking for conflicts, you find them regularly. The journals are doing a very nice job now asking people voluntarily to submit their conflicts with any papers that they submit, but I don't know that the guideline developer community has taken this as seriously as they may need to. Often there's a little paper shuffling at the beginning of a session, define your conflicts, and this gets put into a notebook somewhere. The IOM based on evidence that is recounted in the document, I think is very clear that conflicts pose a real threat to the validity of guidelines, and we need to be very careful about management without specifying exactly what form that might take. And so, because, to repeat the question, because federal agencies both fund studies and fund guideline developments that may result from those studies, there are potential conflicts that are in play. You have very special issues, and you wonder whether these may be largely intellectual conflicts, because a lot of the monetary conflicts are taken care of by federal guidelines. It's a great question. If I could give you the answer in 30 seconds, I would be happy to, but I think it's something that is really very important. NIH funds so many of these studies as well as funding guidelines. They're in the same boat that you are, and maybe you guys ought to get together, the funders and guideline producers, and decide what makes the most sense for federal agencies in this realm. There are federal regulations, I am told, that make it necessary for reviewers of draft guidelines to declare their authorship. So Jimmy clarifies that this is not applicable in all situations, and that the specific statements may not necessarily be attributable to their authors. You may need a list of authors, but that may not be tied to their specific comments.
I was just going to say, it seems like that this issue of sort of being specific on what the risk-benefit model is that you're using can be important. You know, what kind of approach do you take? Do you take a precautionary approach? There are other approaches, cost-benefit approaches. I wanted to point out you could make your statement two different ways, and this, I think this may be relevant to some other areas of public health too. You could say, what is the evidence that there is harm? You could also say, what is the evidence that this exposure is safe? And being very explicit how you value that seems to be important to me. Are you saying, what do you say if there isn't good evidence one way or another? Do we say, we haven't demonstrated that we have sufficient evidence that people can be exposed to this? Or do you say, we haven't demonstrated that there's sufficient evidence that there's going to be harm? So I'm not sure that all this necessarily fits directly with the models that are that are relevant to clinical practice.
So intellectual conflict of interest is difficult to deal with. Is the point that was made. I can't agree more. It seems to me that one of the most effective ways to deal with conflicted panel members is to balance them. So if you know you've got somebody with an intellectual conflict, if you can balance him with someone with an alternative conflict in another direction, that seems to work very well as can be expected. Asking people up front whether they are willing to trade their biases in the face of evidence, and making there be an explicit expectation that if the evidence goes against your strongly held belief, we're going to vote you down. We're going to make a statement that may be contrary to something that you adhere to strongly. Can you work in those confines? Voting is often useful. When you can't convince people because of intellectual conflicts to join in a majority opinion or in an overwhelming consensus opinion, publishing the vote that it was 11-1 is useful for people who are trying to interpret what to do. But by far, what I've seen being most effective is trying to balance.